Hello everyone. Today I'm gonna talk about stress fractures. My name is Senthil and being senior resident orthopedics in SLIPS. So, what is defined stress fractures? It is first described by the Bot in military recruits. He says it is also called fatigue fractures. It's mostly observed in new military recruits where they're prone to march past hill climbing and everything. It is mostly caused by a overuse mechanism. So, what is the pathophysiology? It's a fatigue failure of the bone to accommodate the stress. So, repeated episodes of bone strain and leads to micro damage, and it will cause micro damage accumulation. There is a phase of repeated phase of micro damage going on due to the repeated episodes of bone strain, and it will produce a clinical symptoms in that patient. It will produce pain, such that there are three stages with the pathophysiology. There is crack initiation, crack propagation, and a complete fracture. So there will be due to this micro damage accumulation, it progresses from crack initiation to a complete fracture. So what is crack initiation? It is sites of stress concentration such as lacunae or canaliculi. It's not a crack initiation phase is not symptomatic in the patient, and the crack propagation occurs along the cement lines of the bone. Rapid expansion when occurs parallel to the cement lines. Rapid failure of the bone. If healing response cannot stop propagation, it causes a rapid failure of the bone. So it is all interconnected, and there is a crack initiation, there is a crack propagation. The crack has initiated, it propagates along the cement line of the bone. When the healing response does not overtake the crack propagation, it leads to the failure of the bone. What is symptomatic crack is 1 to 3 mm. This adaptive response of remodeling in response to crack initiation and propagation is called Wolff's law. The Wolff's law is otherwise been said like bone remodels in response to stress. So, what are the intrinsic factors that causes is altered biomechanics, poor running form, and hormonal imbalance in female estrogen deficiencies. So the patient will have a poor running form and has an altered biomechanics. Male athletes are more prone to nutritional deficiencies and sleep deprivation. In muscle contraction, there is increased stress and leads to micro damage. It is followed by micro damage of accumulation, and there is a fracture. Muscle fatigue, there is less absorption of external forces. The muscle is not absorbing external forces, the entire load goes to the bone. This difference between stress fracture and insufficiency fracture. Stress fracture is high loads on a relatively normal bone. Insufficiency fracture means normal loads on a bone with low healing capacity. That is metatarsal fatigue fracture in elderly household ambulatory. So stress fracture is high loads on relatively normal bone. Insufficiency fracture is normal loads on bone with low healing capacity. Clinical feature. There is a usual history of unaccustomed and repeated activity. There is a load-related pain is the early symptom. The patient will have a pain on when there is a metatarsal stress fracture. He will have a pain on bearing or walking long distance. And you should also look for the general health, medications, diet, and menstrual history in these patients. Increase in training volume or intensity, a change in technique or surface, or an alteration of footwear. You should also look for these histories when there is an alteration of footwear, when there is a change in the technique of the training, or when there is an increase in the training volume. So, what are the imaging modalities? You confirm the diagnosis, take an X-ray to confirm the diagnosis. X-rays are usually normal in the first 2 to 3 weeks after the onset of symptoms. Periosteal response 3 months after the onset of symptoms is noted in the X-ray. Periosteal bone formation, horizontal or oblique linear patterns of sclerosis. Endosteal callus and frank fracture line can be visible after 3 months. Next, we are coming to bone scintigraphy. It is a very sensitive method and it is can confirm clinically suspected cases. Acute stress fractures causes an increased uptake on all three phases of a technetium 99 bone scan, but it lacks specificity. It is positive in many other conditions also, infections, bone tumors, all those things. So, what are the indications for bone scan? When there is a suspected lesions in the spine or pelvis, identifying multiple stress fractures. It's used for distinguishing bipartite bones from the stress fractures. Positive images in phase 3 persist many months and should not be used to monitor healing and dictate return to activity. So you can see there's a bipartite patella, so you should be able to differentiate whether it's stress fractures or it's a bipartite bones. Images positive in phase 3 can persist for many months. It should not be used to monitor healing and in these patients. So next, coming to MRI, it is more specific and avoids radiation exposure, and it is less time and more expensive. Grading the stage of certain stress fractures and therefore predicting the time to recovery. Femoral neck stress fractures in an athlete. So there's order, first we X-ray, then bone scan, then we come to MRI. So MRI is more specific and it is but more expensive. So it is preferably done in suspected case of pathological fractures. So high risk stress fractures, there's a predilection of progressing to complete fracture, delayed union or non-union. So what are the anatomical sites for high risk stress fractures? This table is taken from Rockwood and Green. Consequently, the anatomical sites are femoral neck tension site. There is a tension site and compression site. Tension side is the lateral aspect. Compression side is the medial aspect. The patella, tension side, compression side. Tension side is the anterior aspect. Compression is the articulating surface is the compression side. Anterior tibial cortex, medial malleolus, talar neck, dorsal navicular cortex, fifth metatarsal proximal metaphysis, sesamoids of the great toe. What is low risk stress fractures? Diagnosed on the basis of a thorough history, physical examination and the radiographs. A rest period of 1 to 6 weeks of limited weight bearing. Progressing to full weight bearing phase of low impact activities, high impact activities. So, Kading-Miller stress fracture classification systems, there is 5 grades. Grade 1 is no pain, no imaging evidence of stress fracture, no fracture line. Grade 2 is grade 2 pain, some imaging evidence of stress fracture, no fracture line. Grade 3 has pain present, non-displaced fracture line. Grade 4 has displaced fracture. Grade 5 is non-union. So this is a very important classification system. The radiological findings are is noted from CT, MRI, bone scan or X-rays. As you can see in this image, there are arrow pointed to there is a hyper intense signal. There is edema in the proximal femur shaft. So it has gone for most probably stress fracture. And you can see there is a fifth metatarsal base fracture. It occurs in the zone 2, that is Jones fracture. These fractures are less prone to be less prone for healing, and they usually go for non-union. So it is usually fixed with the screw fixation. So these are the shaft. There is a spiral oblique fracture in the distal shaft of the humerus. So this is, I think, talar neck fracture, talus fracture, and there is some healing going on, and the sclerosis is also present. So what are the differential diagnoses of stress fractures? Stress reaction, periosteosis infection, avulsion injuries, muscle strain, bursitis, neoplasm, and exertional compartment syndrome, and nerve entrapment. So the treatment overview, fundamental principle of initial management is rest to allow bone remodeling process to equilibrate, identifying and correcting any predisposing factors, hormonal replacement therapy, and training errors. When the abnormal training position, abnormal training form, overactivity, you should identify and correct all those things. So usually initial management, treatment management is a treatment for as rest for a particular time to allow healing. So this is the flow chart that says protocol to be followed. If stress is diagnosed, so you should look for patient's nutritional hormone status, and you should classify the patient according to his grade. Grade 1 is observational, grade 2 the anatomical site, the low risk sites relative rest, with the high risk sites complete rest. The low risk site relative rest and symptoms persist, no imaging evidence of interval healing. After 6 weeks, you go for complete rest. Symptoms persist or no imaging evidence of healing after 6 weeks, surgical fixation. High risk patient, you go for complete rest. When the symptoms persist or no imaging evidence of interval healing after 6 weeks, you go for surgical fixation. The grade 3 is anatomical site, low risk and high risk. Low risk patient in the grade 3 is more or less same as the high risk patient in the grade 2. And the high risk patient in the grade 3 go for surgical fixation. Type 4 is also surgical fixation. Type 5 is surgical fixation with bone grafting. This is the flowchart taken from Rockwood and Green. This is the protocol and the management of the stress fracture. Prevention. The training error is most frequent culprit and should be corrected. Assessment of the type and condition of the running shoes. Viscoelastic insoles may help reduce the incidence of lower extremity stress fracture. And parents should be educated, coaches, military personnel should be educated about the periodic rest. Female athletes have altered biomechanics of the knee or eating disorders and hormonal abnormalities. You should look for all those things and correct those things. So the stress fracture in the vertebra is spondylolysis. As you can see that Scottish dog appearance is seen. There is a broken Scottish dog neck, they say. So spondylolysis can go for spondylolisthesis is also present. There is some grade 1 spondylolisthesis is present due to that stress fracture. So that's it occurs in the pars interarticularis. SPECT scan is a gold standard for diagnosing spondylolytic lesion. Where there is hot phase, there is an increased uptake. The treatment is avoid lumbar hyperextension. If the symptoms persist, use a non-rigid brace for 2 to 4 weeks. If the symptoms still persist, you can go for TLSO. Femoral neck fracture is a high complication rate due to hip musculature fatigue due to prolonged activity or subsequent loss of shock absorbing effect. There's muscle overaction of the muscle or loss of muscle to absorb the shock. The more common is the compression type, which is the benign type, usually managed with the non-vein bearing for 6 weeks and weekly X-ray. Distraction or tension stress fracture starts in the superior cortex. There is high chance of displacement and progression. Grade 3 or grade 4 tension set femoral neck fracture should be stabilized with multiple screw fixation to promote healing and prevent displacement. And you should avoid the lateral entry points below the mid portion of the trochanter. This is the stress arising area. As you can see in the subtrochanter is a more stress arising area. So you should allow the mid portion below the mid portion of the trochanter to avoid the lateral entry points. Femur shaft fracture, pain on palpation. As you can see in the image, it is called hanging leg text. So the patient that has the clinician puts his arm under his thigh and with the other arm he presses the knee over that arm. The patient will have a hanging leg text. It's a protected weight bearing with the crutches for 1 to 4 weeks. The tibial fracture actually is the most common site of the stress fracture, that is a high load bearing area, that is 20 to 75%. Posteromedial cortex is the most common site. It's a compression site of the tibial fracture, most common. Most common, it is a low risk fracture. Transverse fracture is most common. Conservative treatment, pneumatic brakes, early return of activities. Anterolateral cortex is a high risk stress fracture. There is a constant tension from the posterior muscle forces and hypovascularity of the anterior aspect of the tibia predispose the site to non-union or delayed union. So the treatment is reamed intramedullary nailing is recommended. This too, as you can see in the X-ray, they have done interlocking intramedullary nail. So coming to medial malleolus, there is a repeated impingement of the talus on the medial malleolus during ankle dorsiflexion and tibial rotation. The fracture line is vertical or horizontal. Athletes desiring early return to competition with a complete fracture line requires surgery. So medial malleolus can also go for a stress fracture during repeated ankle dorsiflexion and tibial rotation. Navicular stress fracture is usually seen in sprinting and jumping sports, mostly due to poor blood supply and high risk fracture site. Tenderness at the navicular spot. Acute fracture initial 6 period to non-vein pericast immobilization, delayed diagnosis or delayed union, compression screw stabilization. Displaced fractures and established sclerotic non-unions require ORF and supplemental bone graft. As in the CT image, you can see the stress navicular fracture. So this patients will usually require a period of immobilization for 6 weeks. So it is fixed with the partially threaded cancerous screw. So fifth metatarsal, proximal fifth metatarsal is high risk fracture site. There is a cortical hypertrophy occurs in the running and jumping athletes, rendering the zone relatively avascular with a narrow medullary canal. Cast immobilization for 6 weeks in high demand athletes to early return of activity, go for screw fixation and weight bearing after 7 to 14 days. So So these are the these are the zones: zone 1, zone 2, zone 3. So zone 2 is what we call zones. The junction of zone 2 and zone 3 is what we call zones. Acute fracture is a non-vein bearing cast immobilization, immediate delayed union, intramedullary compression, screw placement after the medullary canal of the fracture site has been adequately drilled to remove fibrous tissue and sclerotic bone. Established non-union before grafting. Functional metatarsal brace should be used for at least 1 month after surgery to prevent re-injury. Grade 2 sesamoid can also go for stress fracture. It's predominant at the medial sesamoid. Repeated dorsiflexion of the grade 2 during running and jumping activities and weight bearing on the anterior posterior view and lateral view as well as the axial view centered on the sesamoids. Acute stress fracture is treated with 6 weeks of non-weight bearing cast that extends to the tip of the toe to prevent dorsiflexion. Sesamoidectomy is another treatment to relieve the pain. This is a sesamoid bone that is gone for a, you can see there is a fracture of the sesamoid bone. So it's all about today's topic. As you can see, the stress fracture, the important is that proper management of stress fracture. There is a flow chart. The other one is grading classification of the stress fracture. And you should look for stress fracture. You should have, you should be properly, you should not miss stress fractures in the athletes, female athletes, patients who are military recruits. So all those patients you should for stress fracture. So thank you.